Good afternoon, everyone. I'm here to present the results of my research entitled Comparison of Conventional versus Customized 3D Printed Bolus for Chest Wall Radiotherapy in Breast Cancer. I'd like to thank my supervisors, Pejman, Mahsheed, Zaid, Suki, and Wawick. I'd also like to thank the University of Western Australia and Sir Charles Gairdner Hospital for providing this opportunity and all the equipment for the research. So breast cancer is the most common cancer for women in Australia. It's the second leading cause of cancer death. More than half of the people in whom there's a recurrence of breast cancer, it's in the chest wall. So the image on the right shows the PTV highlighted for chest wall treatment. So it's really important to perform post-mastectomy radiotherapy to avoid locoregional failure. This can be done mainly with tangential photon beams, and for certain areas like the medial part of the chest wall, electron beams can be used as well. According to ICRU Report 50, the dose to the tumor on the surface needs to be between 95% to 107% of the prescribed dose. For high energy beams, there's skin sparing effect. So to ensure that, we need to use a bolus. Air gaps can be observed between the bolus and the skin if it cannot precisely conform to the skin, and the location of these air gaps cannot be ascertained before the setup. So it's not possible to account for them in the treatment planning system, and that's why their effect needs to be assessed and the air gaps need to be minimized. So these are some studies who assess the effect of air gap. Basically, they showed that the dose reduction caused by the air gaps is affected by the size of the field and the angle of incidence of the beam. Some studies showed the use of 3D printing to make boluses customized to the skin. So this was one of the first study by Kim, and they introduced this general procedure where you can take the CT scan and then contour the region, perform volume rendering, and then 3D print a bolus in the treatment planning system. A few more studies have been done. However, these studies, after creating the bolus, the dosimetric evaluation has been done in treatment planning system. In this study, it was aimed to do in treatment planning system along with dose measurement on a phantom. So the research objectives to quantify the effect of air gaps on surface dose for Eurosil-4 Pink sheet. This is the Eurosil-4 Pink bolus, and this is the other paraffin wax bolus which was used. So the effect of air gaps, we also need to consider the effect of field size and angle of incidence for this. And then we needed to construct two different thicknesses of the customized Eurosil-4 Pink bolus, and the optimal thickness needed to be checked as well. Finally, we needed to compare the dosimetric properties of the customized Eurosil-4 Pink bolus and the paraffin wax bolus. So for the air gap analysis, these were the prerequisite materials. Some bolus sheets made of Eurosil-4 Pink. It was checked that they have a uniform density, their thickness was checked, and they could be stacked to give other thicknesses as well. Air gap stands to create a certain size of air gap in the setup. These were 3D printed with PETG, and these thicknesses were created. And we used ion chamber for the air gap analysis, and instead of just using it in solid water, it was thought it's better to make a sheet to insert the chamber with the same material as the bolus. So Eurosil-4 Pink sheet to insert the ion chamber. So it was specific to CCO4, and it was made sure that the ion chamber is at the surface of the sheet and the center of the sheet. So when the beam is incident, it's at the center. For the air gap analysis, I found the effective field size from the patient plan. So the patient plan was a VMAT plan of 2 arcs, and first this was imported in Eclipse. This shows the VMAT plan with all the MLCs. So first, the gap size was calculated for each leaf pair at each control point. And then after averaging, we got the average gap size of 2.8 for all the MLCs. And then average beam area. So for this, the individual gap size needed to be multiplied with the individual MLC width. And all of that needed to be summed up for the given control point and then averaged out for all the control points to give the average beam area of 63.5. Dividing 63.5 by 2.8 is 22.7. So it can be said that the effective field size of the VMAT plan was 2.8 centimeters times 22.7 centimeter. And when this was used for air gap, this is how the field looked. So treatment planning, CT scans were taken for these setups. The first one where all the boluses were stacked together. The second one where an air gap was inserted between the sheet containing the ion chamber and the bolus. And this was done for all the air gap sizes. These parameters were used and treatment planning was done in Eclipse after importing the CTs. And then dose was calculated. First, for this one, at all the depths, which were 0.02 centimeter apart. So that would be same as finding surface dose for different bolus thickness. And then for this one, to find the surface dose, the ion chamber was contoured, and we had an average dose and standard deviation as well for the surface dose for the given air gap size. And then the plans were delivered for the different thicknesses, and dose was measured with CCO4. Plans were delivered for different air gap sizes, and this was repeated with the effective field size that was calculated before. And the gantry angle was changed to these angles, keeping the field size same as the effective field size. So these were the different cases of measurements for air gap. So that was the first part. In the second part of the project, a customized Eurosil-4 Pink bolus was created. So this is the bolus. You can have a look. It was created from this 3D printed shell. So the process was, first volume rendering was done in 3D slicer, and then these were, this was imported in mesh mixer, where the region, including the tumor, was selected. It was extracted out, and then it was extruded to the thickness which was required in the bolus. This was printed with 0% infill and PLA. And then we got the 3D printed bolus shell, which was hollow, which was filled with Eurosil-4 Pink to give the Eurosil-4 Pink boluses. So these are the boluses and the shell. So the thickness was verified with vernier caliper. To assess the dosimetric properties, I created a 3D printed chest phantom, which was also customized to the patient because patient CT was used. With patient CT, we made the model and hollowed out the internal volume. And then we printed in 4 parts, filled each one of them with water, and glued them back together to give the final chest phantom. So for each of the bolus, planning CT was taken along with the different boluses. And these CTs were imported in Eclipse, and treatment planning was done, same as the actual patient plan for the patient which was selected for this study. And these were the parameters of the patient plan: 6 MV photon beam, 2 arc VMAT, and these were the 2 MUs for the 2 arcs. So in the Eclipse, first the position for the film was determined. It was contoured, 10 points were selected, and we got an average dose for the film. So the average dose was calculated for the film, and then the surface was contoured separately to get the surface TVH. The plans were delivered for all the 4 cases. As you can see, the film has been placed on the isocenter. So this was no bolus, and then the different boluses. So this was the paraffin wax bolus that was used for the patient. So the results of this study, first finding the optimal bolus thickness for the customized bolus. So the black one is the measured dose in ion chamber, and the red one is the calculated dose in TPS. The dose has been normalized to maximum dose, and both of these gave a maximum dose at 1.1 centimeter. So that's why this thickness was used for one of the customized Eurosil-4 Pink bolus. And then using the 10 by 10 field size, which is relatively a larger field size, this was the reduction in dose that was observed with the ion chamber. The reduction wasn't quite high for this field, and this was the calculated dose. It was not as expected, and there was very large standard deviation. And this is because when the field is incident on this, the bolus is causing one buildup, and then the air gap is causing another buildup. So the dose we're measuring at this point is lying on the second buildup, and the eclipse is not good at calculating dose lying in second buildup. So that's why we had a very large uncertainty and a very large standard deviation. So for this study, we considered the measured dose to be appropriate for the results. These results are also in agreement with the findings of Khan and others. So this was with the 10 by 10 field size, and this was with the effective field size. And the same, the red one is 10 by 10, same as the last slide, and this one is the effective field size, the blue one. And clearly, with the effective field size, the reduction in dose is quite high. It's 2.52% compared to 0.5% of 10 by 10 at 1.5 centimeter air gap thickness. So this means that when small fields are used, such as in IMRT and VMAT, the air gaps can be critical. Using the same field size and changing the angle of incidence, this blue one is without an air gap, and the red one is with 1 centimeter air gap. So it was seen that for 1 centimeter air gap at 60-degree angle of incidence, the dose reduction was as high as 6%, which is quite considerable. So for techniques like IMRT and VMAT, again, it's very important to consider air gaps. So also, it was aimed to see all different thicknesses for the customized bolus. So this is one control point of the VMAT plan, and this is a chest phantom and 1.1 centimeter customized bolus. And this is the thickness along the beam. So although the bolus is 1.1 centimeter, the effective thickness was an average of 2.34 and 1.29 for this control point. So it was higher than the actual width of the bolus, although it wasn't calculated for all control points, but it's clear that the effective thickness can be high. So in clinics, usually we use a bolus of thickness 0.5 or 0.6 centimeter, and when it's kept like this, curved on the patient, or the beams are oblique, the effective thickness can reach as high as 1.1, which was the optimal thickness we found for the customized bolus. So that shows why we got that thickness. So for the measurements on chest phantom, a radiochromic film was used, and this is the calibration curve for that. The red channel had a very good R-square of 0.998, and it was used because it's more sensitive. So the calculated and measured dose for on the film for all the boluses. The Eurosil-4 Pink boluses were able to escalate the dose as compared to the case of no bolus as efficiently as paraffin wax bolus, which is commonly used in the clinic. It can also be observed, these red lines are the dose limits as per ICRU, so 95% and 107% of the prescribed dose. the paraffin wax bolus, the dose for that exceeds the maximum limit by a larger amount compared to Eurosil-4 Pink boluses. So this is a cause of concern because in that sense, paraffin wax bolus is not optimal for use. So next, this was the film region that was contoured, and this was the surface region that was contoured for DVH. And this is for 1.1 centimeter bolus, so there's dose escalation. And this was the surface and body DVH. So x-axis is the dose, y-axis is the ratio of total volume in percentage. The dotted line is the body DVH, and the solid line is the skin DVH. Green is for 6 millimeter Eurosil-4 Pink bolus, blue is for 11 millimeter Eurosil-4 Pink bolus, red is for paraffin wax, and black is for no bolus. And this orange line is the total prescribed dose, which was 27 gray. So this area beyond this line, the red one is the paraffin wax. This area is quite large, and it indicates that there was a very large amount of dose, larger than the prescribed dose, which was being delivered for the paraffin wax bolus. Although even the Eurosil-4 Pink boluses are exceeding it a little bit, but the area is quite less compared to paraffin wax bolus. So this can be a cause of concern because it can cause skin reactions like radiation dermatitis or even skin cancer. So in order to eliminate that risk, it's better to use the Eurosil-4 Pink bolus. So the conclusion of the study, it's important to consider air gaps for IMRT and VMAT since they have small fields and oblique beams. The Eurosil-4 Pink is a very good bolus material because it's tissue equivalent, it's malleable, and it has a good adhesion to the surface. It can also conform well to the patient when the patient is breathing or the patient has gained weight compared to the last radiotherapy session. So the surface is not the same, but if other substances like PLA and ABS are used, which are used in many customized boluses in like the previous studies, they are solid and they cannot do a good job for this. But Eurosil-4 Pink, which is basically just silicone rubber, it can be beneficial for that. And the study showed that these Eurosil-4 Pink boluses were also good to shift the maximum dose to the surface and ensure tumor control. These boluses can be clinically implemented, and further examination can be done to validate that. So in this project, I learned 3D printing, MATLAB, dosimetry with film and ion chamber, treatment planning, dose delivery, scientific writing, and I was able to write a paper based on the research, and I was able to submit it to JMRS. For future, Monte Carlo analysis can be done for the air gap study, and different thicknesses and materials of bolus can be tried to reach the dose as close to 100% of the prescribed dose as possible. The sample size can be increased. The bolus can be made for other types of cancer. Modulation of dose distribution can be done. And in this study, the angles considered for incidence were less than 60 because when we did more than 60, the size of air gap was not being able to maintain. And that's why in future, new methods and new setups can be explored for those angles to try to find those dose reductions. Organs at risk can be included in the phantom, and their density can be same as the actual organs, and different materials can be explored for the customized bolus. So thank you for listening.
Difference between the broad fields and the narrow fields, and the fact that the air gap has a bigger effect than narrow fields. What's the physical explanation for that? Why does the narrow field have a bigger impact?
Yeah, thanks for asking. So it's due to the electron contamination. So it has been shown in Khan study as well that when the field is larger, the electron contamination from collimators and the flattening filter is very high, and it overcomes the effect of air gaps. So the dose reduction is smaller for larger fields. For smaller fields, it's not high enough to overcome the effect of air gaps, so the effect of air gaps is more prevalent.
So the study that you did was on the breast. Would you imagine other areas around the body with this change, and if so, what kind of change would you think you might see?
Yeah, that's pretty interesting. I think this study can be used for more curved regions like nose and head. So it could be even more beneficial for that, because for chest it's relatively simple, and when the customized bolus is used for head and neck, I think the larger benefits would be observed. Yeah.
So I just wanted to clarify, because I believe it's on for the chest wall radiotherapy and breast cancer. I just wanted to confirm this was for is this for post-mastectomy patients that it's been specified for?
Yeah. So generally it's done after mastectomy, but
Yep.
this patient, because of age and other factors, surgery wasn't possible for this patient.
Yep.
So only radiotherapy was done. But
Okay.
generally that's the order.
So would that, in essence, mean that this could also be a very similar technique that they could use for, say, skin cancers, given with mastectomy, obviously the chest wall would actually be quite close or very similar?
I think so, yeah, because they would require bolus in that as well, and I think, yeah, it's totally useful for that as well. Yeah.
Yep.
This is for the left side we're talking about. But usually these left-sided are done with the DIBH.
Mm-hmm.
So to
Yep.
reduce the hard dose